I welcome you all to second vertical integration seminar on tuberculosis. Please keep the silence. Please maintain the silence. Please hold on. Please hold on. Please hold on. So today we have a special guest, Dr. Badnapur. He is a leading community medicine from IIMSR. And he has working as the World Health Organization consultant for prevention and control of tuberculosis. For each area, we have one research consultant who is with us, and so I request all of you to welcome by the good round of applause. So, welcome, and he is also one of the judges for the today's event, and also at the end of the program, he will give some free inputs because he is working in our Nagpur division, you can say for Marathwada, for the prevention and control and treatment of tuberculosis. So we will hear from him in the last. Okay. So without delaying, we are ready for 15 minutes. We will start the presentation. First presentation is by Amir Khan from 2022 batch. He will be talking about the applied anatomy of lungs to tuberculosis. So I request Amir Khan to come and start the presentation.
Good morning everyone. Today we are going to decode tuberculosis, but not from your usual microbiological, pathological or even pharmacological point of view. We will be looking at TB from the anatomical point of view. TB is not just a disease. It's like this Bollywood villain who finds its way into every corner of your body, and anatomy explains how. By the end of today's session, you will see that if you understand the anatomy, TB starts making complete sense. These are the points that I will try to cover in my session today. First, we will try to understand the importance of anatomy in understanding TB. Secondly, we look at the anatomical pathways that TB abuses for its spread. And third, we look at the common sites that are affected by TB, which will then explain the symptoms and complications that are caused by TB, but from an anatomical point of view. First, we look at the respiratory anatomy, starting with the lungs. The lungs are the favorite hangout spot for TB. Here is a random fact for you guys. India has the largest TB burden of cases, and 70% of these cases involve the lungs. TB usually affects the upper lobes of the lungs. Now why you may ask so? It is because it has high oxygen tension. Now I have one question for you guys. Why are the lower lobes spared first? Does anyone want to answer? It is because that the lower lobes have higher perfusion, therefore the TB gets cleared by the lymphatics more effectively. Once TB is done with the lungs, it tries to enter the pleura and the hilum. When TB hits the pleura, it causes pleural effusion and pleural thickening, but that is all pathological. What does it have to do with anatomy? Now just imagine a patient comes to you with all the classical symptoms of TB, but he is showing sharp localized pain in his chest. This would mean that the affected nerves are the intercostal nerves, therefore the affected pleura is the costal pleura. But if the same patient presents to you with the same classical symptoms of tuberculosis, but this time he is showing referred pain to his shoulder, now the affected nerve has become phrenic nerve, therefore the affected pleura is not diaphragmatic pleura. This is why anatomy is important. Secondly, we will look at the hilum. Now consider hilum as the Mumbai airport for lungs. Bronchi, arteries, veins, lymphatics all enter and exit from here. Especially in kids, the lymph node enlargement in the hilum is even larger than the lung lesion itself. This is because in kids the lymphoid tissue is hyperactive. Now I have one more question for you guys. Why is bronchocompression more common in kids rather than adults? Does anyone volunteer? It is because, as I said, the lymphoid tissue is hyperactive and the airways are comparatively smaller than adults, therefore they are easier to compress. This is also why lobar collapse is more common in pediatric TB rather than adult TB. Now we will be looking at the FedEx or the courier service for tuberculosis, which is the lymphatics. Tuberculosis first enters the superficial and deep lymphatic plexuses in the lungs. Then it enters into the hilar lymph nodes. Once it has entered into the hilar lymph nodes, all ways of lymph nodes are open for tuberculosis. Next we will look at the spread pathways of TB. Now TB is not your usual Sarar Sikandar or wrist Larsen. What I mean to say is, it's not a gentleman and it does not respect boundaries. It will use any tactics possible to spread. Therefore, the most common pathways used are hematogenous spread, direct spread, and spread through venous plexuses. When tuberculosis uses hematogenous spread, it enters the bloodstream and enters entire body, causing multiple organ dysfunctions, which is also termed as miliary TB, as it shows millet seed nodules in the chest X-ray. Secondly, we have to look at the direct spread. TB can enter the body cavities like pleura, pericardium, and also through the pericardium it can enter the spine and cause Pott's disease, about which we will discuss later. Third, we have spread through venous plexus, more commonly known as the Baxton plexus. It is a valveless venous plexus which forms a direct shortcut from the lungs to the vertebra. No visa, no passport, no pleura, no pericardium, straight from lungs to the vertebra. Now we look at some symptoms, but we look at them from the anatomical point of view. Now symptoms are something that makes the patient come to you. These are some of the more common symptoms. First being cough. TB when enters the lungs, it causes bronchial damage. The chronic inflammation then destroys the bronchial epithelium, therefore triggering the cough response. Secondly, chest pain. As I said before, in the pleura part, the affected nerves are intercostal nerves as well as the phrenic nerve, which lead to chest pain. Now third, back pain. Either through direct spread from body cavities or from the direct connection of Baxton plexus, it can enter the spine and cause Pott's disease. Now Pott's disease leads to vertebral damage, which then causes something known as gibbous deformity. Now this gibbous deformity then causes a cold abscess that starts from your psoas and enters as a swelling in your groin region. Just imagine an infection that starts from your back but now is presenting as a swelling in your groin region. That is anatomy at play. Third, hoarseness of voice. Now this is when the anatomy gets fascinating. The recurrent laryngeal nerve is a branch of vagus nerve, and there are two different pathways based on whether it is the right recurrent laryngeal nerve or the left recurrent laryngeal nerve. The right one loops around the subclavian artery, while the left one loops around the arch of aorta. They both ascend upwards from the tracheoesophageal groove, which is in close proximity to both the hilar as well as the mediastinal lymph nodes. So the compression of these lymph nodes by tuberculosis then compresses the recurrent laryngeal nerve, leading to hoarseness of voice. Finally, the flank pain. When TB enters the kidneys, it can cause papillary necrosis, and TB in kidneys is also known as an imitator, as the symptoms caused by renal TB are very similar to that caused by kidney stones as well as pyelonephritis. Apart from these, some other symptoms like when TB enters your meninges, it can block the CSF systems, therefore it can lead to palsy of various cranial nerves like 3, cranial nerve 6 and cranial nerve 7. It can enter the abdomen and it can cause ileocecal tuberculosis. Now ileocecal tuberculosis is the most common type of tuberculosis found in abdomen. This is because there is stasis of blood there are Taylor's patches, and also the ileocecal valve is smaller and narrower. Now we'll move forward to the anatomical complications of TB. Now this is when the damage really starts to get high. First is the bronchopleural fistula. In simple terms, it is a tunnel from your bronchus to your pleura. that is known as the bronchopleural fistula. Anatomically, the bronchus, the lesion collapses and it enters into the bronchus. Secondly, we have kyphoscoliosis. When TB becomes Pott's disease, it then causes the anterior vest deformity, which later turns into angular kyphosis. This angular kyphosis is also known as gibbous deformity. Now, in older times when severe cases of TB were seen, TB was also commonly known as the hunchback's disease because this symptom was very common. And when TB affects your genitals, it can lead to infertility. Finally, I would like to give you some takeaway points. Tuberculosis, you should not look at tuberculosis as an infection, but it is more like an anatomical storyteller. Every spread, let it be from like lung apex to kidneys, meninges to abdomen, every spread, every symptom, every complication has an anatomical basis to it. So, thank you guys. I am Ahmed Khan, roll number 33, batch 2022. You guys have been an amazing audience. Thank you.
Thank you, Ahmed Khan. That was a powerful presentation by the Ahmed Khan. He has given the importance about the anatomical aspect, and it was not only lungs, the whole body. There are two organs in the body which are not affected by tuberculosis. Can you name them? Sorry? Hair and nails. Very good. So, all other parts, they are affected by the tuberculosis. And tuberculosis is a very old ancient disease. So, what was the ancient name for the tuberculosis? What name was given to it? No. Ancient name. Character of man of death. Okay, this is the name given for tuberculosis. Now, what is the organism which causes tuberculosis? Mycobacterial tuberculosis. So, mycobacterial tuberculosis plays a very important role. So, now we see the mycological aspect of tuberculosis by the Musfira Khan.
It is a cytoplasmic layer, aramidogalaxy layer, the microlic acid layer, the lipid layer, proteins, and the plasma. Now, this plasma membrane contains a very important antigen, which is the lipoaramidin. This facilitates the growth of the mycobacterium bacteria in the microphages. So let's come to the lab diagnosis of tuberculosis, where we use microscopy to do culture and also we do the molecular diagnosis. The first step we do is, of course, we have to select the specimen. The most important specimen is the sputum, as in pulmonary tuberculosis. So the sputum is collected in a specialized sputum collection area, which is located far away from the population and in well open ventilated space. It is collected during early morning and the stomach. It is conveyed. While collecting, the patient is supposed to take deep breaths 2 to 3 times, and then it is collected in a wide open mouth container which is sterile. It is cleaned properly and labeled. Now the quality and the quantity should be, it should be thick mucus, it should be purulent yellow color, and it should be around 3 to 5 ml. Other samples can also be taken, like gastric lavage can be done, tissue samples can be taken, lymph nodes and various body fluids are also used for extrapulmonary tuberculosis. Now direct microscopy by acid fast staining. So we do 3 types of staining, that is the ZL staining, we do neutral staining, we do fluorescent staining, and also we do neon staining. So the ZL staining, we prepare a smear and we do the primary staining by carbon crystal, we decolorize it, but also we have to heat it, then we decolorize it, and then counter stain it with methylene blue. We can then observe it under the microscope. It appears as long, slender, beaded, and it is less uniformly stained, red colored bacilla, as you can see in the diagram. Next is neon staining. It is similar to ZL staining. The difference is a pore form, that is no heat modification of ZL staining. So the appearance of the bacteria is slender, red or pink colored dots. It may be curved, it may be bent, it may have a weird appearance. It is here against a blue or green background. Next one is the fluorescent staining. So the staining is done with the fluorescent dye, which is the auramine phenol. When it is decolorized by acid alcohol, it is counter stained by the potassium chloride. Now this is examined under a specialized fluorescent LED light emitting diode microscope. So the appearance is bright yellow green colored dots against a dark background. Now culture method. This is the more standard method for tuberculosis and it is more sensitive than the microscope. It indicates viability and it is useful for drug sensitivity testing. So basically we use 2 types of media. One is the conventional media where we use the LJ media, the low stage tensile media, and the other one is the automated liquid culture media where we use the MGI, mycobacterial growth incubated group. So LJ medium, it is composed of hence egg, mineral salt solution, asparagine and lactate. Colonies which are formed in LJ medium takes around 6 to 8 weeks and it is formed as the dark, tough and buff colored colony. Whereas in MGI, the growth detects within 3 to 4 weeks only and the mycobacterium tuberculosis appears as granular or flaky growth. Let's come to the molecular diagnosis. It takes less time than culture and it is also more sensitive. It detects genes which code for the resistance for drugs. So basically we do 3 types of molecular methods: polymer chain reaction, automated real-time polymer chain reaction including CD-NAT, gene exporting MUNAT, and last one is the line flow assay. So polymer chain reaction is detection of DNA of this bacteria in sample by the amplification of specific DNA sequences. CD-NAT, the gene export we use, it is based on real-time PCR and it is a rapid time turnover of around 2 hours. It detects the mycobacterium tuberculosis complex and it is also detecting the right-hand resistant, the gene which is the RPOB gene. The disadvantage is that it is expensive and it cannot further specify the mycobacterium tuberculosis complex. For the extrapulmonary tuberculosis, WHS recommended this as the first initial test which is for the diagnosis. be used as a primary healthcare levels, and it also relates diagnosis and resistance. The total of the time is only about 1 hour. It is less expensive than JIIU. Because it cannot further cascade the hypertension to the first strong, and it can only test limited samples, those samples can be done. Line it is a probe-based vector amplified gain in the sample using the reverse hybrid. So the pros are that it identifies the MTB complex. It also specifies the manufacturing tuberculosis complex and also non-tuberculosis manufacturing. It also detects the gene coding for the resistance to not only the first line drugs but also the second line antibiotics. But the con or the disadvantage is it can inform only on culture or smear possible specimens. Diagnosis of latent lesion. So this is very useful for screening purposes and for the epidemiological purposes. It is based on type 4 hypersensitivity, grade hypersensitivity reaction. So the first test is the tuberculosis skin test where we inject the antibody, the antigen in the vessel of forearm, and the medium is taken up to 48 to 72 hours where an intubation is formed surrounded by cellular erythema. If it is more than 10 mm or 10 mm, then it is a positive result. And if it is less than 5 mm, then it is negative. It is doubtful and neutral. It can also give false positive or false negative result. Now, positive result in adults, it can indicate either past or it can also indicate present infection. So that's why it is used as an epidemiological marker and not as a diagnostic marker. Whereas in positive result in children, it indicates active infection. TB, it is the newest skin test used for TB. It is more specific than tuberculosis skin test. And the last one is interferon gamma release assay. Now, sensitized T lymphocytes are collected from the suspected individuals, which are then exposed to the antigen, which are very specific antigen, which leads to a release of high levels of interferon gamma. This is very specific method and no false positive results are there. This was in short about the microbiological aspect. Thank you.
So it was a very excellent presentation by Mr. Khan. Microbiology of microtuberculosis plays very important role. All of you have done better studying in your second university, one of the practical in your university exam. And at PhD level also, when the sputum samples are sent to PhD, there is one TB technician who is supposed to examine and diagnose. So, diagnosis is a very important part. In tuberculosis, we see diagnostic algorithm later on. Before going to that, we will have now see about the problem of tuberculosis because it is one of the public health problem in the world as well as in India. That's why the WHO is concerned, IIMSR is concerned, Government of India, Minister of Health and Welfare is also concerned, public health services are also concerned, and we have a national program for the tuberculosis. And what is the name of the program? So I invite Afra Khan for her presentation on the epidemiology of tuberculosis.
with diabetes mellitus. So if there is more disease immunity, it increases the susceptibility. Now we see the environmental factor. In environment, low socioeconomic status, poor hygiene, overcrowding increases the vulnerability. Then we have the agent. So for the agent, as we know, tuberculosis is caused by Mycobacterium tuberculosis, which is a facultative intracellular acid bacteria, and it belongs to typical Mycobacterium. And we also have a class known as atypical Mycobacterium. So the typical Mycobacterium, it affects new lungs, whereas atypical, it infects the already diseased lungs, so it is less relevant. Whereas typical, it is highly relevant. The typical Mycobacterium is spread from the direct contact from human beings, whereas atypical, it does not spread by direct contact. And the typical Mycobacterium, they are non-pigment producers, whereas atypical, they produce pigment. So example, as we already said, in typical Mycobacterium, we have Mycobacterium tuberculosis, whereas atypical, we have Mycobacterium consalvi, Strobiluarium and Fortunium. And also, the typical Mycobacterium, they are sensitive to the standard antimicrobial drugs, whereas atypical Mycobacterium, they are resistant. Now we see the disease as a whole, tuberculosis. So tuberculosis, it is a worldwide public health problem. And talking about pulmonary tuberculosis, the term pulmonary, it means it affects the lungs. Whereas bovine tuberculosis is the one which infects the cattle. And humans get an infection through consumption of contaminated milk. But due to the customary practice of boiling milk in India, the chances are less. Then we are having extrapulmonary tuberculosis, that is involving organs other than the lungs. So it includes the intestine, the meninges, the bones, the joints, the lymphatic system and the skin. Now talking about the problem statement in the world. So as we said, that tuberculosis, it is a major worldwide public health problem. And you know what? That 1/3 of the total population currently is asymptomatically infected with tuberculosis, and out of which 5 to 10% will develop the disease later in their life. And the people who develop the TB disease, of which they are contributed in the 30 high-burden countries, which contribute 87% of the worldwide total, and of which only 5 countries themselves contribute to 56%, which includes India, which contributes 26%, Indonesia, Philippines, China and Pakistan, which contribute to 20%, 10, 8.3, 6.3% respectively. Now the World Health Organization has set standards for international tuberculosis care, which are intended to provide facilities to all patients of TB in entire age group, which includes the smear positive, the smear negative, the extrapulmonary tuberculosis, the drug resistant and those with an association with HIV. So for that, it has set 3 standards, that is 6 standards for diagnosis, 9 standards for treatment and 2 standards for the public health responsibilities. And as you know, that tuberculosis, there are various factors which increase the susceptibility. So it includes smoking, alcohol consumption, indoor air pollution, poverty, overcrowding, decreased immunity. And do you know what? That tuberculosis is a public health problem, and it is a barometer for the social welfare, because it includes all the aspects that are involved for human beings, like the family, the environment. If it spreads to one member, it can infect 10 to 15 individuals. So obviously it will involve all the family members, because there is no age boundary. Then environment, as we said, environmental factors like overcrowding, low socioeconomic status, those are affected. Poverty, occupation, that is the those starting to the migrant laborers, and drug. You know what? That tuberculosis, when the patient starts consuming the TB drug, within 48 to 72 hours of consumption of the drug, 90% of treatment is achieved. So the patient thinks that I'm cured, why do I need to take the treatment? So he takes the treatment, due to which there is development of drug resistance TB, which makes the condition even more worse. Now, the World Health Organization NTB strategy was adopted by the World Health Assembly in May 2014, and it has set down standards to reduce the TB deaths by 90%, cut the new cases by 80% between the year 2015 and 2030, and lastly, to eliminate and reduce the catastrophic cost to 0%, so that no family suffers from the cost due to TB disease. Now let's see about our area. The burden of tuberculosis in India. India is the highest TB burdened country in the world. In association In, in association, highest TB burden country in the world in association with the new cases that come each year. And now what you see here, it is the incidence, total incidence of TB, that is 2800,000, HIV positive TB incidence as 4200,000, and here RR-TB incidence of 110, and HIV positive TB mortality as 8.2 per lakh population. The first one you are seeing there, it is the incidence of TB in the year 2022, which was 199 per lakh population, and it has reduced to 16% from year 2000 as compared to year 2015. And the graph, second graph shows the TB mortality, which is 23 per lakh population, which has reduced to 18% as compared to the year 2015. And now what you are seeing, it is a graph which indicates the death and cause due to diseases, in which tuberculosis contributes to 10th highest cause of mortality in our country. Now we see the age and sex distribution. So TB, it is more common in the ratio is more in males as compared to females. While as I explained, that is tobacco smoking, alcohol consumption, substance abuse lead to increase in males. And in females, you know the cause? In females, it is due to increased incidence of undernutrition, increased incidence of undernutrition in women. Then they are having low decision making, restricted mobility. And you know what? TB kills more women in the reproductive age group as compared to all the causes of maternal mortality combined. And in our India, 1/3 of female infertility is caused due to tuberculosis itself. And the victims of this disease, as you know, tuberculosis is the disease of the poor. So it affects those living in the private pockets, slum dwellers, migrant laborers, undernourished, poverty and overcrowding. Now we see the epidemiological indices which help us in evaluating, controlling and planning measures so as to control TB, which includes incidence. We know that incidence it includes the new cases. Prevalence it includes the total cases at present time, that is new plus old cases. Then we have mortality. Mortality are those deaths which occur due to TB, but in HIV negative people. According to ICD-10, International Classification of Disease. Case fatality rate, it is the risk of death due to TB in active TB disease patient. Case notification rate, it is the reference of new as well as second cases to WHO. The case detection rate, it is calculated as the number of notification rates in new and relapsed cases of TB in a given year upon the estimated incidence of same cases in the same year. And prevalence, it is those TB cases who exhibit the TB bacilli, which is drug resistant. Then we have the definition of cases and treatment. That we are having case definition and treatment of outcome definition. So first, based on classification of anatomical side of disease, we are having pulmonary tuberculosis and extrapulmonary, which is defined as the biologically evident and clinically diagnosed cases of TB. And if it is found in the lungs, it is called as pulmonary. If it is found in other organs, it is called as extrapulmonary tuberculosis. Whereas relapsed patients are those who had been given previously treatment of TB. They got cured and then they had a second episode of TB. Then we are having treatment after failure patients. So who are these? These are again the same who got treatment, but at the end of the treatment, they had failed treatment at the most recent course of their treatment. Then we have the treatment after loss to follow. So these are previously treated patients who had been delivered loss to follow at the end of the most recent course of their treatment. Then we have the previously treated patients with unknown TB treatment, which include those individuals who were previously treated but their outcome at the end of the recent course of treatment was unknown. Then based on the drug resistance, we are having mono resistance, that is resistance to only one line first antitubercular drug, poly more than one first line antitubercular drug, multi that is resistance, drug that is resistance to both iodinic acid and rifampicin. Then we are having extensive drug resistance, that is resistance to fluoroquine, along with one of the three second line antitubercular drugs, which includes canamycin, caprimycin, and amitriptyline. And rifampicin resistance, as you see, it is resistance to rifampicin itself. Then, based on HIV status, we are having HIV positive, negative, and status unknown. So, HIV positive TB patients are those who are on clinical diagnosis and biological evidence. Their result shows positive on HIV testing. When negative are those whose result shows negative on HIV testing, and status unknown who do not show any result only based on HIV testing.
was a very nice presentation by the Pratnam talking about the problem of tuberculosis throughout the world. Now we will move on to the next presentation. That is on pathogenesis of tuberculosis, how the disease of tuberculosis is caused, how the symptoms are presented, how the disease spread inside the body, what kind of immunity takes place after the microorganism enters into the body. So for that we have Taura Salina from 2022.
Assalamualaikum warahmatullahi wabarakatuh and very good morning to respected teachers and my dear friends. I am Taura from batch 2022 will be discussing pathogenesis of tuberculosis. Here it shows infection before activation of cell-mediated immunity. Mycobacterium tuberculosis enters into the macrophage through a process known as phagocytosis. It is mediated by a receptor present on macrophage. The name of the receptor is melanoid-binding leptin enzyme-free complement receptor. As the bacteria enters into the macrophage, it will block the formation of phagocytosis and this will allow the bacteria to replicate. Here it shows initiation of cell-mediated immunity before activation. Here it shows initiation of cell-mediated immunity. Macrophage and antigen of mycobacterium tuberculosis bind to each other through a receptor known as plasma receptor. This activates T cells. T cells will form T helper cells, and T helper cells release interferon gamma, which will activate macrophage. This activated macrophages release TNF and chemokines, which will recruit monocytes, and this leads to formation of granuloma. Granuloma comprises of epithelioid cells, monocytes, and central irrigation. Now we will see how there is replication of mycobacterium tuberculosis in. Now we will see how there is replication of mycobacterium tuberculosis in macrophage. Mycobacterium tuberculosis replicates in macrophage by blocking phagolysosome. It blocks phagolysosome by recruiting colobin on the membrane of phagolysosome. Colobin activates calcitonate, phosphatase calcitonate, which lead to which will block phagolysosome. Here, primary tuberculosis in non-immunized individuals leads to formation of replication of mycobacterium tuberculosis in underground macrophages. Now we will see how our immunity reacts to the bacteria which has already entered into the body. Mycobacterium tuberculosis makes some patterns which are recognized by our immunity. These patterns are mycobacterial lipoarabinomannan and CTC nucleotides. The mycobacterial lipoarabinomannan binds to TLR2 and acetylalated CTC nucleotides binds to TLR9. This initiates the instant immunity. Now we will see how pH infection goes in latent phase, on reinfection it will cause secondary tuberculosis. Secondary tuberculosis when progress, it will lead to massive heterogeneous dissemination and this will cause severe tuberculosis. Same is the case with primary tuberculosis. When primary tuberculosis progress, it leads to massive heterogeneous dissemination and this will lead to biliary tuberculosis. On reinfection, secondary tuberculosis will lead to formation of localized caseation. Same I will explain you in tabular form. Here it shows on exposure to multiple tuberculosis in non-living host, mainly in children, it causes primary tuberculosis. Primary tuberculosis will lead to formation of bone complex. It comprises of hilar lymph nodes and bone mucus, which on healing by fibrosis will lead to development of immunity and hypersensitivity, and this will cause tuberculosis positive. And if multiple tuberculosis, bacteria in primary tuberculosis progress, it will lead to unimmunized individuals and malnourished individuals, it may lead to death. And if primary tuberculosis causes severe bacteremia, it will lead to biliary tuberculosis and it may cause death. And if primary tuberculosis spread by lymphatic materials dissemination, it goes into various organs and it may go into dormant phase, which on deactivation will cause secondary tuberculosis. When secondary tuberculosis goes in severe cases, it may lead to extrapulmonary tuberculosis. Now we will see what extra tuberculosis occur in our body. Extra tuberculosis may affect any organ of our body, such as in lymph node, it will cause lymphadenitis. In pleura, it may cause tuberculous pleuritis. In pleura, it will cause tuberculous pleuritis. In skin, it may cause lupus vulgaris. In bones, it may cause Bonn's disease. In skin, it may cause lupus vulgaris, and this will lead to extrapulmonary tuberculosis. Now I will summarize my topic. Extrapulmonary or external mycopathic tuberculosis, it enters into the body, which will enter into the alveolar macrophages. There it will replicate, and this will lead to initiation of innate immunity, which will lead to formation of plasmatic inflammation, and there will be tissue damage. Thank you very much for being patient listeners.
So it was a very nice presentation by Paula. She is the girl who was insisting for presentation in the first seminar also, but I told her to wait for a second. Now she has presented very well. So I request all of you to please give a big round of applause for her. Now next we have the once the microorganism enters into the body and person suffers from infection and he develops a disease. How a person is going to present to the clinic or to the hospital, we'll see by the clinical presentation of tuberculosis by Jalna.
low-grade fever, loss of weight, appetite, as well as chronic cough with an expectoration for past examination revealed long, slender, and acid-fast bacilli. The X-ray image has been shown. So, anyone from the audience wants to volunteer for the answer? The first option, that is pleural tuberculosis, second pulmonary tuberculosis, third genital tuberculosis, and the last, that is tubercular empyema. This is the X-ray which is showing the fibrosis of the lungs. Anyone? Yes, very good. That is the pulmonary tuberculosis. Now let us start our discussion with the manifestations of tuberculosis. The first and the most important feature, that is the cough which is persistent for more than 2 weeks, fever, generally the low grade fever, which is the evening rise of temperature is seen, third, loss of weight, which further loss of appetite, which further leads to the weight loss, and the last, that is night sweat. Along with this, the other features such as the blood in the vomiting, that is hemoptysis, can be seen. Along with these, the other features such as easy fatigability, weakness, other clinical features are seen. Heading towards our discussion with the pulmonary features of tuberculosis, it is divided into 3 forms: primary pulmonary tuberculosis, secondary pulmonary tuberculosis, and the third, that is biliary tuberculosis. Let us discuss about the differences between primary pulmonary tuberculosis and the post-primary, that is related, or the secondary pulmonary tuberculosis. Primary pulmonary tuberculosis results into the initial exogenous infection of the bacteria, that is tubercular bacilli, whereas the secondary or post-primary results due to the endogenous reactivation of the latent primary lesion. The most common age group affected in the primary is in the children, whereas in the post-primary it is adults. The clinical features are same, but along with this, the typical feature which is seen in primary pulmonary tuberculosis, that is nothing but the pleuritic chest pain. The last, that is depending upon the lesion, how we will differentiate between primary and the secondary, that is the bone focus is seen in the primary pulmonary tuberculosis, whereas the sinus focus is seen in the post-primary pulmonary tuberculosis. Now, how will we differentiate on the depending upon X-ray whether it is bone or sinus? Bone focus usually lies in the lower part of the upper lobe, whereas the sinus focus usually lies in the apex of the lung. As we have discussed in the previous slide, that is due to the reduced oxygen in that area. Now, heading our discussion towards the biliary tuberculosis. What is biliary tuberculosis? Biliary tuberculosis is nothing but a severe form of tuberculosis which is caused by widespread dissemination of mycobacterial tuberculosis through the bloodstream. The bacteria gets lodged in the lung spaces from in both of the regions, and you can see that these green patches which has been formed in the lung field. A typical finding which can be seen in biliary tuberculosis in the X-ray, and anybody in the audience can tell. It is no strong appearance which is seen in the X-ray in biliary tuberculosis. Heading our discussion towards the extrapulmonary tuberculosis. The most common site involved in extrapulmonary tuberculosis is lymph node, then pleura, and other sites such as bone, joints, meninges, pericardium, and genitourinary system is involved. This is the diagrammatic picture showing the manifestations of extrapulmonary tuberculosis from adults. Now let us discuss these features from systematically. First, CNS, nephrology. TB, meningitis, the clinical features such as headache, vomiting, seizures, and delirium can be seen. Along with these, the other features such as hydrocephalus and tuberculosis. Tuberculosis from orthopedic point of view, that is skeletal tuberculosis, clinical features such as chronic back pain, kyphosis, and the cord compression. Importance of tuberculosis from serious point of view, that is tuberculosis, TB, pericarditis. The two typical features in TB pericarditis, that is the pericardial effusion and constructive pericarditis. Importance of TB from surgical point of view, that is from JIIU. The 3 symptoms that is seen: exudative ascites, mesenteric adenitis, and the intestinal obstruction. The tubercular feature from genitourinary point of view, that first the clinical feature that is seen blood in the urine, that is hematuria. Second, infertility in the women, and the epididymitis prostatitis is seen in males. Now imagine you are sitting in an OPD, a patient with tuberculosis comes to you and literally coughs on you. If the patient with tuberculosis comes and coughs on a healthcare worker, the bacteria gets lodged in the tonsils, it travels from there and gets set in the lymph node, giving rise to the painless cervical lymphadenopathy, which is matter in consistency. The most common site involved is the posterior channel of the lymph. It leads to the cold abscess eroding through the skin and creating a fistulous tract. Other features such as pleural tuberculosis. Pleural tuberculosis, as we have seen the clinical manifestations in the primary and post-primary tuberculosis, here I will discuss about the X-ray finding in pleural tuberculosis In the females, it is the fallopian tube which is most commonly affected than the endometrium, leading to the infertility. And as I have discussed in the males, it is orchitis and prostatitis. From orthopedic point of view, skeletal tuberculosis most common set involved in the lower thoracic or the upper but lower vertebra in the adults, presenting with a clinical feature that is paraplegia. It is a formation of giblus over the vertebral body due to the destruction of vertebra caused by the bacteria. The most common joint involved spine is more commonly affected than hips and than the knee. Cords disease, that is more than 2 vertebral cords are involved. Last, tubercular meningitis. Tubercular meningitis, the cranial nerve pulses are seen with the presence of pus which is moving from the base of the brain. The clinical features such as open deficits due to the endarteritis, hydrocephalus is seen. How do you investigate? Investigation for tubercular meningitis will do CSF analysis, and usually there is elevated proteins about 2 to 8 grams per deciliter. A specific finding which you will see in the CSF analysis, that is a cow-like appearance due to the formation of fibrillin. Now last, we will discuss about HIV along with tuberculosis. This was a recent question on HIV and tuberculosis asked on the RC-NEET 2025 head-on turnovers. A 30-year-old man presents with a chronic fever and significant weight loss. Chest X-ray shows right upper lobe infiltrate and the sputum is positive for acid-fast bacillus. During the examination, he is found to be HIV positive. So what is the most appropriate management plan? So what do you think? You will treat his HIV first or you will treat ATD first, and that is tuberculosis first. Yes, tuberculosis. You have to set the community first of all, no? That therefore you have to give ATD first and then initiate ART after 2 weeks. Now, what will happen if you treat HIV first of all? If HIV is treated first of all, there is a syndrome, if anybody knows, that is iris syndrome, that is immune. Iris syndrome, what happens in iris syndrome? If you give ART first, immunocompromised state is improved. And when immunocompromised state is improved, and then the symptoms has been worsened secondly. Therefore, you have to give ART, that is tuberculosis has to be treated first and then ART. These all are my references.
So it was fantastic presentation by the Seva. She has not covered the academic part, but she has given me feeling that this topic is also one of our PGD. So she has shown you GIIU for the PGD exam. So it is your duty not only to prepare for not only for the PGD but also for the PG exam. Now we will move forward to next presentation. There is a diagnostic algorithm by the Pusna Manish.
Tuberculosis remains one of the top 10 causes of death worldwide, despite being fully treated. Early diagnosis of tuberculosis not only saves one life, but also prevents its further spread. So we know how important a proper standardized diagnostic algorithm is for a deadly disease like tuberculosis. So to discuss the diagnostic algorithms, various diagnostic algorithms of tuberculosis, today I am Team Shade is here, starting with what is a diagnostic algorithm? A diagnostic algorithm is basically a stepwise pathway which starts from symptoms, moving on to tests, moving on to confirmed diagnosis, and eventually leading to treatment. It basically ensures accuracy, standardization, and faster decisions. Now, what are the benefits of early diagnosis? Early diagnosis basically stops disease progression and complications, reduces community community transmission and detects drug resistance on time. What are the benefits of early treatment? It basically helps in faster symptom relief, breaks transmission chain, and prevents MDR, SDR, TB, and also supports elimination, TB elimination goals. Now today, the major topics, the major TB diagnostic algorithms that will be studying about is adult pulmonary TB, extrapulmonary TB, pediatric TB, HIV associated TB, and lastly drug resistant TB, which includes MDR and SDR. Starting on with adult pulmonary TB. Now, persons with cough which lasts for more than 2 weeks with or without other symptoms are suggested of TB and are considered as presumptive TB case. Now we'll look at the flowchart for a presumptive TB case. We'll start with smear examination and chest X-ray. Now smear examination and chest X-ray can lead to the following 4 results. The smear might be positive and the chest X-ray is suggestive of TB, which will eventually lead to the following flowchart, which is if it follows the PMPD criteria, we can diagnose it as tuberculosis. Moving on, if the smear is positive, but the chest X-ray is negative, but the chest X-ray is not suggestive of TB. So we can again we will discuss the PMPD criteria further. So if the chest X-ray is suggestive of TB and the smear is also positive, smear is not positive, it will undergo PMPD criteria and it will eventually be confirmed as multifactorial tuberculosis. Moving on, smear negative but the chest X-ray is suggestive. The smear is negative but the chest X-ray is suggestive of TB. It will undergo CBNAT, which is cartridge-based nucleic acid amplification test, which will eventually lead to 2 results. First is it might be multifactorial tuberculosis positive. If it comes out positive, we can check for rifampicin resistance. If it is rifampicin resistant, it is considered as tuberculosis. If the rifampicin is indeterminate, it will undergo second sampling and which will also include liquid culture and nitric acid. Moving on, if there is rifampicin resistance, if there is rifampicin resistance, we can follow the PMPD guidelines, which will be talking about further. Lastly, if the smear is negative or the CBNAT is not available, but the clinician is highly suspicious, so we can start with tuberculosis regimen in such patients. Moving on, extrapulmonary TB. So for extrapulmonary TB, the TB spreads to various other parts of the body. So for that, we need the sample of the part of the body where the TB has spread. That sample can undergo CBNAT or liquid culture. If the sample is available and it undergoes CBNAT and tuberculosis is detected, then it is considered confirmed extrapulmonary tuberculosis. If the tuberculosis is not detected, then that is a negative result. And also, if the tuberculosis is detected, the resistance of the rifampicin, which we have discussed earlier, should be done again. Moving on, liquid culture. If the liquid culture is positive, it is confirmed tuberculosis, and if the liquid culture is not positive, then the tuberculosis is negative. And lastly, if the sample is not available, like in some cases, if the sample is, we are not able to take out the sample, but the clinician is highly suspicious that the patient might be a tuberculosis patient. So we can either use other diagnostic tools and we can come with alternate diagnosis. Moving on, pediatric TB. So for pediatric TB, there needs to be persistent fever lasting for more than 2 weeks without a known cause, or unremitting cough, which is also for lasting for more than 2 weeks, weight loss more than 5% or no weight gain in the past 3 months, failure of nutrition rehabilitation in babies with severe acute malnutrition, and lastly, if the baby has come in contact with a patient with pulmonary tuberculosis in the past 2 years. So in such patients, we only take a chest X-ray and not a smear. Now, why would we not take a smear in pediatric age group? It is because the sputum, a baby is not able to give a proper sputum sample, and even if we get a sputum sample, the sample is highly unreliable. So in pediatric cases, we only take a chest X-ray. So if the chest X-ray is suggestive of TB, we can either take a sputum sample if possible, or a gastric aspiration, or a IIMSR and follows the same pathway. If it is confirmed tuberculosis, then we can check for resistance of rifampicin. Now, if the chest X-ray is not specific, we can start with antibiotics such as amoxicillin and amoxicillin, and we should avoid drugs like quinolones and neonatal because it might lead to drug reactions in pediatric age group. And if the antibiotics, even after giving the antibiotics, if the symptoms still persist, we should take a sample of gastric aspiration or induced sputum to check for and give it for CBHAT. Moving on, if there is pleural effusion in pediatric age group, the pleural fluid should be sent for MAT, cytology, biochemistry, and if it comes positive, it is a confirmed case of TB. But if the pleural effusion sample comes out negative, but the sample is straw color exudative effusion, and no other alternative diagnosis can be made, then it is considered as a probable case of TB and should be treated in such manner. Moving on, if the chest X-ray is normal, we should check for extrapulmonary tuberculosis in pediatric. This is what we have already talked about: persistent fever and close contact mentioned in the flowchart. Moving on, HIV-associated TB. On cases where adults are exposed, living adults with HIV are having symptoms such as cough, fever, weight loss, night sweats, they should be evaluated for tuberculosis. Now, how does our diagnostic algorithm of HIV and a normal tuberculosis patient differ? It is because there are investigations which are specific for such patients, which is LAM. Urine is tested for LAM, which is a protein, and if the CD4 count is less than 200, then it is considered as tuberculosis. Also, we can also do a CT scan for extrapulmonary tuberculosis in such patients. Lastly, moving on with drug-resistant TB. Now, for drug-resistant TB, there is a regimen which is PMPT, which I have mentioned earlier, which is Program Management of Drug-Resistant Tuberculosis. In that, there is a shorter oral bedaquiline introduced, which is for 6 months, and it is a potent oral regimen, and no injections are administered in such patients. So, here's the flowchart. Rifampicin resistance is detected. Then we can send a second sample for first line amyloid acid, second line amyloid acid, liquid culture drug susceptibility testing, bedaquiline resistance testing, and further drugs are there. And after the pre-treatment evaluation is done, we can check on the labs, and if no additional resistance is detected or isoniazid resistance is detected, we can start a shorter oral bedaquiline regimen, which is for 6 months. And if resistance is detected, we can start a longer oral, which is considered as an NDR-HDR regimen. That, and also, if additional resistance or intolerance is seen in such patients, then we can, in the shorter regimen patients, then we can move them on to the longer oral regimen in such patients. That is it from my side. Thank you so much.
It was a very extensive presentation. So we were supposed to touch on the part of diagnosis for various forms of tuberculosis. But not only she has shown the diagnosis, but also the some regimens also she has described for the medicinal tuberculosis. So once we have diagnosed tuberculosis, based on the diagnostic algorithm, now we go for the management of tuberculosis. So I invite Sami from Regimental Batch to talk on management of tuberculosis, which is a very important part and aspect of tuberculosis. tuberculosis is one of the most common infectious disease and is a major cause of the death worldwide. So, TB is a global health challenge, and today we stand here at the forefront, united by passion to combat tuberculosis. So, with this, good afternoon everyone. I am Samir Khan from Batch 21, and I will be discussing about management of pulmonary tuberculosis. So, beginning with a quick introduction, tuberculosis is a communicable chronic granulomatous disease caused by Mycobacterium tuberculosis. So, to begin with the management, in this scenario, we will consider a case of pulmonary tuberculosis of an adult patient. So, for example, if you are a practicing physician and a patient approaches to you with a complaint with the clinical features of TB, which are maybe the cardinal features of TB, fever, chronic weight loss, chronic cough, fever, and weight loss. So, apart from that, how will we be dealing with that case? So, it begins with taking the proper history of TB contact, familial history, and examining the patient. Apart from that, there is a certain list of investigations which we usually perform to diagnose TB. At the end of the management, before the management, your goal should be early diagnosis, effective treatment, and prevention of drug resistance. This is the goal on which majority of the tuberculosis drug regimen is based. So these are the set of investigations which we perform to diagnose TB. So starting with the specimen collection, sputum is the most common specimen. 2 specimens spoken early morning. Apart from that, if sputum turns out to be negative, but you feel the patient presented to you is TB positive because of the clinical features, what you can do is you ask for the chest X-ray. Chest X-ray helps to diagnose the pulmonary tuberculosis. Then acid-fast staining, which is ZN staining, fluorescent organ staining. In culture, the conventional culture media for tuberculosis is Belgian media, Johnson media. It usually takes more time because of the generation time of the Mycobacterium tuberculosis. Automated culture identification, molecular method, in which CBNet is the gold standard test for tuberculosis. Its turnaround time is around 2 hours, and it helps in detection of resistance of tuberculosis and identification of Mycobacterium. Then we have line assay. So now looking about the radiological finding. So here is the 2 list of radiological investigation. Above one is the chest X-ray. Okay, so above one is the chest X-ray. The findings of the chest X-ray in pulmonary tuberculosis is ill-defined opacification in one or both of the upper lobes. As the disease progresses, you can see the patient is presented with consolidation, collapse, and even cavitation develops to varying degrees. Apart from that, pleural effusion or thickening may present. Second image is of CT scan. So CT scan finding it generally shows parenchymal and lymph node lesion. Apart from that, there is a typical presentation seen in the CT scan of tuberculosis patient. It is a tree-bud appearance. So it is highlighted there in the CT scan image. So these are the individuals with risk of infection of pulmonary TB and increased risk of progression to active TB. So we have 2 TBs, active TB and latent TB. Active TB is the TB which is occurred first time, and the latent TB is the relapse or it is reinfection of tuberculosis to the same individual. So talking about the generalized approach to manage tuberculosis. So pulmonary tuberculosis generally follows established guidelines that focuses on diagnosis, treatment, and prevention. Diagnosis, treatment, monitoring and follow-up, prevention, and managing social comorbidities such as TB with HIV, TB in pregnancy, TB with diabetes mellitus, TB with malignancy, etc., and so on. Okay. So talking about the counseling part of the TB. So TB is not like the other typical disease where a patient presents to you and you just prescribe the drugs. And patient को बोले कि हो गया ये drugs ले लेना, you have to leave. TB is a long chronic disease and it has to be counseled well before starting any drug regimen in case of tuberculosis. So most patients with uncomplicated TB and all patients with complications or adverse drug reaction due to anti-TB drug should refer to a TB specialist, first of all, or pulmonologist. Most TB cases can be treated fully at home with instruction on how to prevent the spread of disease. So you have to instruct the patient whenever patient is diagnosed with pulmonary TB for the first time, you have to explain him the basic measures which include staying at home, avoiding meeting or contacts or going to crowded place, wearing a N95 respirator mask and switching to protein diet and adequate hydration, and registration at NICSHAN web portal. So NICSHAN web portal, since you all might be knowing TB is a notifiable disease, and once a patient has been diagnosed with TB, whether you practice at government setup or private setup, you have to make that patient register at this web portal, which is called as NICSHAN portal. So the advantage of this NICSHAN portal is that the patient gets free FDCs, the fixed drug combination of anti-TB, and it helps in deciding the regimen for the patient. Talking about the pharmacological part, so anti-tuberculosis drugs are classified as into two types: first-line drug and second-line drug. So what are first-line drugs? First-line drugs are those drugs which are more efficacious in action and which are routinely used with lesser toxicity. It includes following 5 drugs, out of which the streptomycin is the injectable form and it is labeled as supplemental first-line drug. The other 4 first-line drugs are rifampicin, isoniazid, pyrazinamide, and ethambutol. Alongside here, you see the drug dose, which is as per the weight of the patient guided by WHO. All the first-line drugs are available as FDC because the mechanism of action of each drug varies slightly. Some drugs are more useful in the case of extracellular tubercular bacilli. Some of the drugs are more useful for intracellular tubercular bacilli. So the combination of all the first-line drugs in the form of fixed dose combination helps in treating the TB and preventing the emergence of resistance. Okay, so coming to second-line drugs. So generally we advise treat the patient with first-line drug, but in case of there is a resistance of TB, which is very common in tuberculosis, we also add on second-line drugs. So in second-line drugs, we have the categories of drugs: fluoroquinolones, injectable second-line oral drugs, and unclear efficacy drugs. Okay, so coming to the treatment regimen. So the treatment regimen of a newly diagnosed pulmonary TB includes of 6 months, which is the initial 2 months is called as intensive phase, in which we give HRLV drugs, the 4 drugs, and in continuation phase, which is of 4 months, we give HRA drugs. So in intensive phase, we try to kill the bacteria rapidly, and the remaining bacteria are killed and tackled during continuation phase. There are the common side effects of first-line drug. Isoniazid, the peripheral neuritis, is very common. So make sure you prophylactically give pyridoxine, which is vitamin B6, at a dose of 10 mg per kg, 10 mg per day. Then the other side effects are hepatitis, neurological manifestation. Rifampicin, it has a very common side effect of orange secretion. So before starting all this drug, you have to advise the patient, brief him about the entire treatment, the side effects, the common side effects of the drug, and most importantly, the adherence of these drugs for the entire treatment regimen. Third is the pyrazinamide, most hepatotoxic drug, nausea, vomiting, hyperuricemia, and other side effects of pyrazinamide. Next is the ethambutol. Yes, the most common side effect is retrovalvular optic neuritis. So you have to be cautious while dealing with the pediatric tuberculosis. Now strategies to treat TB. So aims of tuberculosis treatment. Whenever you start any treatment, there is some aim that you have to consider these guidelines and you have to do it accordingly. So it is to interrupt the transmission of tuberculosis, to prevent morbidity and death by curing, to prevent the emergence of drug resistance, and to prevent relapse. So to achieve the aim, following strategies have been practiced. First is the multi-drug therapy. So there is a combination of drugs used in multi-drug short-course chemotherapy. So eventually, when TB treatment was beginning in 1990s, during those times, the TB treatment course was of longer duration, around 18 to 24 months. But now it is switched to around 6 months, 6 to 12 months. The
the short course chemotherapy, then two-phase chemotherapy. Again, the two-phase chemotherapy is intensive as in the continuous phase. Then we have the dot strategy, in which all the tuberculosis drugs are given under the supervision of a physician or a doctor. Treatment regimen: standard regimen for drug-sensitive TB, regimen for drug-resistant TB, follow-up treatment. So, for laboratory investigation, so since puberty is the most common specimen used to deal with the tuberculosis diagnosis, sputum smear examination is done at the end of intensive phase. Also, long-term follow-up needs to be done in case of TB since it's a chronic disease, and adherence is very difficult. Compliance is very poor with regards to patients. So, it is carried up to 2 years of complete treatment. Okay, so intensive management, apart from the drugs, patient should be made aware about the nutritional support, which is the protein supplementation and calorie supplementation. Pyridoxine again for with isoniazid, corticosteroids in cases of comorbidities like TB, meningitis and pericarditis. Lastly, to conclude my presentation, TB remains a major challenge in today's time as well. Switching to adequate regimen and early detection is the cornerstone in treating the condition. Adherence monitoring is very critical of the patient, and the future goal depends on shorter, safer, and more effective regimen. So that's it. Thank you for listening so patiently.
So that was the presentation from Samir Khan. He has started from introduction to diagnosis and so many things we have included, but not described the management in detail. Actually, he was supposed to describe the management of tuberculosis only, but he has encroached to the other topics also. So it's okay, no problem, but he has described about the first line anti-tuberculosis drugs and second line anti-tuberculosis drugs, which plays a very important role in treatment of tuberculosis. Now we move now to next. Is management of drug-resistant tuberculosis by Rita Ashar from 2022 batch.
Tuberculosis every day is a threat to people everywhere. These words of the WHO reminds us that the fight against TB is not just medical, it's global, it's personal. Respected judges, teachers, and my dear friends, today I stand before you to speak on topic that is challenging yet full of hope, the management of drug-resistant tuberculosis. So what exactly is drug-resistant tuberculosis? It is defined as when the manufacturing tuberculosis develops the resistance against anti-tubercular drugs. In simple words, the bacteria has learned to fight against a medicine. It can be classified into monodrug-resistant tuberculosis, polydrug-resistant tuberculosis, multidrug-resistant tuberculosis, and extensive drug-resistant tuberculosis. We'll see each one individually. So first, multidrug-resistant tuberculosis in this, the patient specialized is resistant to vaccine and isoniazid with or without resistance to any other first-line anti-tubercular drugs. So, before starting the treatment, the patient must undergo pre-treatment evaluation. This ensures safety, proper drug selection, and better outcome. So, the pre-treatment evaluation consists of number 1, clinical evaluation, which includes complete history, physical examination, and assessment of symptoms like ophthalmic and neurological. And number 2, laboratory tests. Number 2, laboratory tests, which includes CBC, random blood sugar, LFT, KFT, ECG, chest X-ray, HIV testing, etc. This step is crucial because it not only guides the correct regimen but also prepares the patient mentally and physically for the long journey ahead. Now the heart of management, the regimen. The preferred regimen is 6 months PPAM regimen. The PPAM stands for Badnapur, predominant phenolphthalein moxifloxacin. It's a 26 weeks entirely oral regimen in which a higher dose of methamphetamine is given for the first 2 weeks, then it is reduced in dose and frequency over the next 24 weeks. The other drugs taken are taken once daily for the full 26 weeks. This regimen must be taken with food and pantoprazole added to prevent drug-induced neuropathy. It is indicated for multi-drug-resistant tuberculosis, rifampicin-resistant tuberculosis, pre-extensive drug-resistant tuberculosis, patients over 14 years of age. And it is contraindicated in resistance to any of the first 3 drugs. Patients with significant heart and liver dysfunction, patients below 14 years of age. But most importantly, it is not recommended in the pregnant or lactating females. Number 2, 9 to 11 months or more shorter ART regimen. It consists of 2 phases, intensive phase which lasts for 4 to 6 months and continuation phase lasting for 5 months. Drugs in intensive phase are badnapur, liver or moxifloxacin, clofazimine, pyrazinamide, high-dose isoniazid, and jalna. Drugs in continuation phase are levofloxacin, moxifloxacin, clofazimine, pyrazinamide, and ethambutol. After the treatment comes the follow-up and support. Ophthalmic evaluation, CBC, repeat and are necessary steps. So the second type of drug-resistant tuberculosis is extensive drug-resistant tuberculosis. In extensive drug-resistant tuberculosis, it's like an NDR case whose bacilli is additionally resistant to a fluoroquinolone and one or more secondary anti-tubercular drugs. For the extensive drug-resistant tuberculosis, the WHO recommends an 18 to 20 month long all-oral regimen. It includes for effective drugs such as badnapur, linezolid, clofazimine, cycloserine, and zelenide in extensive phase, followed by at least 3 active drugs in the continuation phase. This approach ensures that even the most resistant strains can be managed with the hopeful cure. Here also, follow-up and support are essential. Monthly clinical examinations, every 6 months chest X-ray, cultures every 2 to 3 months, psychosocial counseling, nutritional support, socio-economic assistance, etc. are essential. Another type of drug-resistant tuberculosis are mono and polydrug-resistant tuberculosis. When the mycobacterium tuberculosis strains are resistant to any one first-line anti-tubercular drug, while remaining susceptible to other first-line anti-tubercular drugs, it is called as monodrug-resistant tuberculosis. And when the mycobacterium tuberculosis strains are resistant to more than one first-line anti-tubercular drug, other than the combination of both isoniazid and rifampicin, it is defined as polydrug-resistant tuberculosis. Moving towards the treatment of monodrug-resistant tuberculosis. According to the latest WHO guidelines, these patients should be treated with 6 months regimen consisting of rifampicin, ethambutol, pyrazinamide, and levofloxacin. If the patient is resistant to rifampicin, then it is managed as multi-drug-resistant tuberculosis. For the rare cases like resistant to ethambutol or pyrazinamide, the regimen is adjusted by removing the resistant drugs and continuing the other drugs for 6 months. Next, the treatment for polydrug-resistant tuberculosis fully depends upon the drug-resistant testing. Combination of the drugs that are still effective, often including a fluoroquinolone such as levofloxacin, along with other first-line or second-line medicines that remain sensitive. Now, the last part, beyond medicine, that is the human side of management. Let me emphasize Managing drug-resistant tuberculosis is not just about drugs. The real success of the treatment depends upon a strong patient care and support. Every patient must receive proper counseling so that they understand the disease, the importance of adherence, and how to cope up with side effects. In India, now we have the JIIU Act, which helps patients stay connected with their health care providers. So, equally important is the nutrition. A weak body cannot fight tuberculosis. There are also government schemes such as Pradhan Mantri Mukt Bharat Abhiyan, which involves community and corporate support to adopt patients and provide them with food baskets and care. So, my respected audience, the management of drug-resistant tuberculosis is like fighting a battle on two fronts: the medical trend with powerful prevention and the human trend with strong patient support. If we combine both modern science and compassionate care, we can move towards the dream of a tuberculosis-free world. Thank you.
So that was a very nice presentation. She has specifically mentioned the regimens which are used for treating drug resistance, whether it is a monodrug resistance, well resistance, multi-drug resistance, extensive drug resistance. So all she has mentioned in a very clear way. We find it very easy over here presently, but when you see a case of XDR or LDR, they literally find difficult to get treated, or chances of cure is very, very less. And ultimately, these the treating physicians, they get so much frustrated that the patient is not responding, and ultimately the patient dies of extensive drug resistance. So that's why prevention is better than cure. Prevention is the only cure. So last part of today's seminar is the presentation on prevention of tuberculosis. So in prevention, we have two forms. One is curative prevention, and second one is the preventive prevention. And in preventive prevention, BCG vaccine is a very important role. So to talk about BCG vaccine, I invite Zoha from 2021 batch for the role of BCG in tuberculosis.
Tuberculosis continues to be one of the world's biggest infectious killers. Every year, about 10 million people suffer from TB and over 1 million die from it. BCG is the only available vaccine against tuberculosis. In fact, every year, 100 million newborns receive BCG vaccine at birth. Let's see history behind BCG vaccine. Bacillus calmette-guerin, that is BCG, is developed by two French scientists, that is Calmette and Guerin. It is derived from attenuated strain of Mycobacterium bovis. It was initially given orally during 1921 to 1925. First human was vaccinated by intradermal technique in 1927. Since then, it has become a part of national immunization schedule. The primary aim is to induce benign artificial primary infections to stimulate acquired resistance against subsequent infection with virulent tubercle bacilli and to protect younger children from severe forms of TB like biliary TB and meningitis. Strains. Tuberculosis BCG is prepared from living bacteria derived from an attenuated bovine strain of tubercle bacilli. WHO has recommended the use of Danish 1331 strain for the production of BCG vaccine. There are two types of vaccine, liquid vaccine and freeze-dried vaccine. Freeze-dried vaccine is more stable as compared to liquid vaccine. Dosage, usual strength of dose is 0.1 mg in 0.1 ml for older children, and for newborn age less than 4 weeks it is 0.05 ml. As skin of newborn is very thin, so we cannot use full dose in newborn. Administration standard procedure recommended by WHO is to inject intradermal injection using tuberculin syringe. The side given over left upper arm, you can notice formation of a small vein which indicates correct administration technique. It is not given subcutaneously as there are certain complications with subcutaneous injection. So this is how BCG is administered in clinical practice. So let's see phenomenon after BCG vaccination. After vaccination, there is formation of a small vacuole at the site of vaccination within 2 to 3 weeks. This reaches to a size of 4 to 8 millimeter in diameter. It either subsides or breaks into shallow ulcer covered with a crust. Healing occurs spontaneously after 6 to 12 weeks, leading to formation of a permanent round tiny scar at the site of vaccination of about 4 to 8 millimeter in diameter. Presence of scar is often considered as an evidence of prior vaccination. Complications. Although BCG is a safe vaccine, it has some complications like local abscess formation, prolonged severe ulceration at the site of vaccination, suppurative lymphadenitis, osteomyelitis, disseminated BCG infection, and even death may occur. So ulceration and suppurative lymphadenitis occur in 1 to 10% of BCG vaccination, whereas disseminated BCG infection is rare and it occurs in only 1 per million cases. Protective value. It is very effective against severe childhood TB like meningitis and biliary TB, but its protection against adult pulmonary TB is highly variable, ranging from 0 to 80%. Despite this, WHO recommends the use of BCG vaccine in all countries where TB is endemic. So revaccination and contraindications. Revaccination is not recommended and it does not provide any additional benefit. Contraindication, it is contraindicated in immunocompromised states like HIV infection, leukemia, lymphoma, malignant diseases. It is also contraindicated in patients who are on immunosuppressive therapy like corticosteroids, alkylating agents, antimetabolites. Other contraindications are pregnancy, hypogammaglobulinemia, infective dermatitis, and generalized eczema. Direct BCG vaccination. In high prevalence countries, including India, we follow direct BCG vaccination technique. In this BCG vaccine is given without prior tuberculosis skin test. It has been adopted as a national policy in many developing countries, including India. It permits more rapid and complete coverage of the eligible population. It reduces the cost and it has no adverse effects even if it is given in tuberculosis positive reactions. So, impact, talking about the impact, it has a huge impact in reducing the childhood TB mortality. 100 million children are vaccinated with BCG annually and it is a part of India's universal immunization program. But BCG is not perfect, it has certain limitations. It does not prevent latent TB and reactivation and its protection wanes with age after 10 to 15 years. So, search for a better TB vaccine continues in the future. There are several vaccine trials, new vaccine trials. First one is M72A01E. It is a subunit vaccine. It has shown 50% protection against progression from latent TB to active disease. Second is BPM1002. It is genetically modified BCG, safer and more immunogenic. It is used in phase 3 trial in India and other countries. And last one is MTB-PAC. It is live attenuated and tuberculosis and early trials are ongoing. These newer vaccines provide a scope for longer lasting and stronger protection in the future. To conclude, BCG remains the cornerstone in prevention of tuberculosis. Although it is not very safe in preventing severe forms, adult pulmonary TB, but it has saved millions of lives by protecting children from severe childhood TB. So that's all. Thank you.
So that was the last presentation from today's seminar. One of the students who was supposed to present the patient of tuberculosis, he has not prepared it, so the presentation will not be there. Before IIMSR comes, he must shoot it. Sir, you want to finish it? do the story. So, before we start and we conclude this program, I would like to invite, please sit down. I know you are having very urgent work. Many of the students are leaving. I know that how serious you are and how much you are studying and giving the seminar. Your senior teachers are sitting here, there is HOD sitting there. I will send the names to HOD. They will take care of it like that you have left the seminar. I have contacted all four HODs for pediatric medicine surgery gynae. Already I have submitted 2 names to them that these people are having indisciplinary behavior in the campus. Please take action. Movements are already informed. So just think about that before you leave the hall. Okay? So I request Dr. Professor Badnapur to come on the dais and enlighten us about his experience of tuberculosis in the field. First.
So firstly, thank you for inviting me as a judge and as well as to speak. And thank you thank you as well as, I think, congratulations to all our speakers. I think we had nine of them, right? So firstly, I think we all have learned a lot. I also learned a lot definitely, and it was very nostalgic because you think of being on that side 10 years back. So what I do is, as I understand, we are very much hard pressed for time. And before that, about the judging, I just say that intrinsically there will be some unfairness. There are different topics. Not all topics are that easy to present. Not all topics are that easy to put together in a slide. Some topics might seem more theoretical, more tedious maybe. So taking all that into consideration, very good effort by all our speakers. So what I do is, usually I really enjoy taking a presentation, which is around maybe at least 45 minutes to 1 hour. We don't have that luxury. I try to sum up in 5 minutes, some few things from, of course, the field experience as well, and a look at NTET. And a look at NTET and CP, how it is right now, as we speak. So we begin with epidemiology. I think our third speaker had gone into epidemiology of tuberculosis. I want to hear from you. Do you think that tuberculosis, I understand most of our students are in third or fourth year, right? Third and fourth, okay. Do you think that tuberculosis has been receiving a lot of attention, extra attention in the last few years? Why? Maybe we have heard this because someone, lot of noise from here, lot of noise from the back end, as usual. Why do you think TB has got so much focus in these last few years?
Because you want to eliminate it.
Yeah, because we are in an elimination phase. Let's just say also because globally, this is not just about India, globally we are in a phase where we can say that 80 to 90% of the work, the hard work of all these years has been done. But then you might say that TB has been there with us since ages, literally. So what is the difference now? There are a few differences because if you look at the past 60 years is when we have more specific antibiotics, specific anti-tubercular antibiotics. And there are of course, one thing, there is no amount of surveillance, containment or any kind of contact tracing and prevention that is going to prevent TB without an improvement in sanitation, nutrition and hygiene. So that way if you look globally, Most countries are slowly improving. Some countries are taking longer, some countries are going to take even longer, but overall there is an improvement. So naturally tuberculosis, now we can say that we are at a phase where 80 to 90% of the work is done. But that is very challenging because this is 2025. There are a lot of other challenges as well. Antimicrobial resistance is a big challenge. Apart from that, air pollution, which is not a new problem. I mean, air pollution has been there since the beginning of civilization, since the beginning of cities, crowded cities, industries, everything. But in the last few decades, air pollution and even climate change, these have been topics which have been more under focus. So what is also happening is that since we are in the elimination phase, let us say the 80 to 90% done phase, now if we become casual about tuberculosis, what happens is in a country like India or in most low or middle income countries, there is already a struggle for resources. What does that mean? We are all in third or final year MBBS. When you say struggle for resources in healthcare, what does that mean? Struggle for resources. What kind of resources are we talking about in healthcare? Everything, right? Health planning. You talk of your infrastructure, you talk of your drugs, you talk of even salaries of the doctors, you talk of the consumer, we speak of all these diagnostic tests, we speak of all these medications, all are resources. You talk of HR, you people who collect the sputum, people who will study the sputum, the lab technicians, the people who transport it, all of these are human resources. So when you say there is a struggle for resources, it means TB is not the only major public health problem in India today. Cancer is waiting there. You have cardiovascular disease family, which is huge. You have neglected tropical diseases, you have antimicrobial resistance, climate change, air pollution, the list is endless. But in that, TB is being prioritized. I mean, there are quite a few which are being prioritized. So what happens is, now if we finish this, get TB down to a level where it ceases being as big a public health problem as it is today, what happens is you can allocate more resources to other problems in the future. That is what is happening in more developed nations. Today they are not spending as much on tuberculosis. Let us say Germany or Sweden or Japan. They don't have to spend as much resources on tuberculosis as India or let's say many sub-Saharan African countries or Brazil or Pakistan or Nepal or even China as these countries have to spend. Right? Talking about the deaths, I think the person who, one of his speakers had mentioned very correctly that it is in the top 10 causes of death, even today. Not just in India but even globally. Actual statistics tell us that there are at least 2 deaths in every 1 minute. I mean, WHO statistics for the last 1 year also tell us that globally due to tuberculosis. And these are the ones which are being reported. Of course, there is a plus and minus in both. That is at a data level, but still, to look at the magnitude of tuberculosis and its mortality as well as morbidity. When we talk of morbidity, there is one more thing. Another one of your speakers had very correctly pointed out that usually it is the reproductive age group. Now, what impact does that have on a country's economy? Reproductive age group economy. See, the reproductive age group, it is not as if reproduction is the only thing they do, right? It is also the working age group. So it means that the working age group, if that gets affected, 6 months you are out of action. Isn't that also a blow to the country's economy? If you see the epidemiological trend in countries like Japan or Germany, where the chain of transmission itself is low, the TB cases are concentrated at age extremes. Either you have children, mostly or more often you have elderly people who are affected due to TB, but not in countries like India, where the chain of transmission is still quite high. You have a lot of people in the working age group. being affected, which also affects the country's economy. Apart from that, of course, I think one of the speakers has also mentioned catastrophic health expenditure, which is a very important concept in preventive social medicine as well. That when a household spends more than, of course, there are two different definitions, let's not get theoretic, but more than 40% of the household's income in a month being spent on health care. In TB, we have even been more liberal, we consider 20%, but even then you have a huge amount of families, like according to the last study, we had 14 to 30% of families in India who have at least one TB patient incurring catastrophic health expenditure because the income, the average income in India itself is low, as you see, right? Okay, so that was about epidemiology. So to sum up a few things, because you guys did a good job, you covered almost all the important aspects, but there are a few things. Presumptive pulmonary TB. So let us just resolve, because all of us are here are either practicing doctors or about to be. So when you sit in your OPDs, when you are interns, I mean, this is very exciting phase up ahead in 1 or 2 years. What we should not do is not miss a diagnosis of tuberculosis. Because two things we can take it upon ourselves are, I could be dramatic and use the word unforgivable, but one is to miss a diagnosis, another one is to miss the treatment. Basically, today's times when we talk of statistics like top 10 causes of death, TB, it is, most of it is actually preventable. And there are very few excuses for, I'm talking of the healthcare fraternity as a whole. If even in 2025 we are losing people to TB, and we do lose a lot of people to tuberculosis. So how do we ensure not to miss the diagnosis of TB? One is to understand what are the signs/symptoms that we should be looking out for. So you have definitely covered, I quickly say, of course, cough, very important, fever, chest pain, pneumocystis. But then apart from cough, fever and a few of these constitutional symptoms, you might not expect these signs or symptoms to be there in many of your patients. So we have to be very discerning. We have to be quite, sensitive to that. Apart from that, of course, weight loss, appetite loss, then you have extrapulmonary TB, which comes with a whole spectrum of signs and symptoms. So in extrapulmonary TB, of course, we have to remember that some of us might expect constitutional symptoms to be very common, but that also depends on the immunocompetent status of the patient. In many extrapulmonary cases, you might not get what are constitutional symptoms? Exactly, what we call as general symptoms. Okay, so now once we have a high index of suspicion to not miss TB, next is to be very sure about the diagnostic cascade. Again, quick summary. Now there's a concept called upfront NAT. So in the diagnostic slide, we spoke about microscopy, we spoke about NAT, LPA, culture as well. But right now, I mean, gold standard, all that we learn theoretically definitely, but in practice, because we have a NAT machine as well in our college, in practice right now for pulmonary TB, especially when you can get a sputum sample, NAT is the go. I mean, that is the go-to diagnostic. Of course, easier said than done. When you don't have the luxury of NAT, which is the reality for majority of India's DMCs, designated microscopy centers, as you may have come across in your PARC textbook, then we still do microscopy. But wherever possible, given an option between microscopy and NAT, we choose NAT. Why do we choose NAT? It is sensitive, and when you say sensitive, two types. Sensitive, when you talk of sensitivity and specificity, also it is more sensitive, and drug sensitivity, in the sense drug resistance is also, and right now it is rifampicin resistance that we use only in the program. But otherwise, you have developments in NAT wherein they have chips that also detect isoniazid resistance as well as fluoroquinolone resistance. So NAT is the go-to tool as of today for detecting pulmonary tuberculosis when you have a sputum sample. Now that is bacteriological confirmation. There could be cases, there will be cases, including pulmonary tuberculosis, where you might get either paucibacillary or even sputum negative samples, or let's say many other reasons. Patient is not able to expectorate, you are not able to get the sputum sample. In those cases, clinical judgment is still a big factor for a diagnosis. What helps clinical judgment? Imaging, definitely. And when we talk of imaging, for example, pulmonary TB, chest X-ray is still a very important tool. And when we talk of other TB, obviously sonography and CT, MRI as and when applicable. So that sums up when you look at the diagnostic thing. One more I just mentioned in the diagnostic algorithm is that when you have NAT, after NAT, when the one sample is taken for NAT, the second sample is set for line probe assay. So this is just a summary because we are still in third, fourth MBBS. All we need to very much remember is the importance of this cascade. That when we talk of LPA, line probe assay, it is very important because it gives us an idea of further drug resistance. Rifampicin drug resistance is the most major chunk of drug resistance, but then there are combinations, and there can be isolated drug resistance to other drugs as well, mostly isoniazid, right? So that's just a summary of diagnostics, and then so quickly, another 2 minutes maybe I to wrap up. So that takes care of diagnosis. Treatment, we have more or less covered. In short, now it is mostly FDC, standard regimen 2 plus 4 months for DSTB. And DSTB, that is drug sensitive TB, is right now around 95% of the caseload that we have is DSTB. But the 5% that is DRTB, drug resistant, accounts for a disproportionately larger percentage of our mortality. So that the rest we have covered already. CYTB and TB. Just wanted to add one thing over there. Is that this was also covered, but I'll just brush it up again. There is TB infection, which, like I say, is around 30% of the population. But in us, when you look at healthcare fraternity and people who are more exposed, obviously those numbers are going to be much higher, especially because we are in India. So now TB infection progresses to TB disease. Only right now it is 5 to 10%, but with time, when we improve in nutrition, sanitation and immunity status that is maintained, that 5 to 10% is going to be even lower. So now to prevent that progression from TB infection to TB disease, we have something called TB preventive therapy, otherwise known as TBT. And of course, we know about Monto test, we know about IGRA, latest is CYTB. CYTB is also a skin test, which is in principle same as Monto test, as the PPD, the purified protein derivative is different. And it is much more specific as well as sensitive. Lastly, when you talk of anti-EB and TB, that is the National TB Elimination Program as well as Tuberculosis in India, what is interesting is that this, I think your last speaker had also put a logo of NICSHARE. So NICSHARE is a platform where TB cases are enrolled with all their details. I mean, India is only the second country in the world where TB case-based data is available on NICSHARE. So, just to tell you that in TB, for those of you who are interested in newer things of, newer aspects of healthcare life, artificial intelligence in health, digital health, antimicrobial resistance, then modeling for intervention, prediction and all that. One thing very interesting about National TB Elimination Program is it has a lot of these newer upcoming domains in medicine. So finally, I'll end by saying that, another point I wanted to mention was BCG. So studies have shown that revaccination could help prolong the immunity against tuberculosis, which is why you might be aware half the districts in the country last year they had a trial. It was a pilot project which is going to be studied for the next 3 years of revaccination, that is adult BCG vaccination. So finally, you are all in third, fourth MBBS. For many of you, best time of your life. My request, my suggestion also would be that we are going into the era of One Health. When we talk of One Health, it means that no domain of healthcare is isolated from everything else. That was how it was many years back. Now we have become very, very specialized. But again, we are going back into that One Health. So when you talk of TB, you have a lot of things that can be covered in let us say, an awareness session or even in other aspects of TB. That could be ranging from antimicrobial resistance to airborne infection control to air pollution and its effects on lung health, TB and lung health, occupational health, lung cancer screening. So there is a lot of scope for intersectoral convergence and collaboration, so to speak. With that, thank you so much for that.
therefore Dr. Kaustov Rajgupta from WHO was mentioning about very important points regarding tuberculosis. Before I invite our PWD sir, he has given a good news for us that the next seminar will be in auditorium. Because for that time we will go to 4 batches, batch 25 will be there, batch 23 will be there, 22 will be there, 21 will be there. So we have decided that next seminar will take place in auditorium once in a month. So I request our PWD sir, please come on that. I request Dr. Neelam to welcome Ishwar Madam on that. We have guests for today, is Dr. Kaustov Rajgupta, and he is also one of the judges for today's program. So I just need sir to felicitate him by giving a bouquet and shawl. And Dr. Jalna, Professor of Medicine, is the third judge for today's program. Please, regular teacher, Dr. Jalna is the third judge for today's event. Now it's time to distribute the certificate to all the participants. We have taken a great effort to make this seminar successful. I invite Amir Khan from 2022 batch to come forward and take the certificate from me, sir. I request Arvind sir, Vinay sir, Suryaman, please join on the stage. Sorry. Amir Khan. Next is Amar Khan. Okay, any questions for the winners for this presentation? It is Bhushan and State from the Second point goes to Sivan Sarwaraj from 2021. First point, any guesses? Yes, this is a powerful presentation. Amen, ma'am. I think all the participants who are stand over here, so let's go to photo. All of you come here. So, Purani. Sorry, I feel So last year I request these to say few words please. First of all, I am very happy that this time boys have taken part in this. And surprisingly, one also. So congratulations. And I don't know how you are handling this, very uncomfortable. So, once again, congratulations to all the participants. And as a formality, we have to go on to the prizes. Otherwise, as I said last time, all are winners. So, I hope that next time the participation will be more. There should be a tough competition for to select the participants. Should be more names. And hopefully we will take it in the order so that the students who are sitting on the ground will sit on a proper chair, inshallah. So all the best. Once again, we can visit all of you for this activity, and hopefully next time I don't know the topic, it will be declared later on. So date and the topic will be declared by the officer. So all the best for the next activity. Thank you. So I finally request thank UK Academic Committee and Curriculum Committee that they have helped me for organizing this program. I will thank you Dr. Pastor Vasudha. Yes, the professor of science engineering in our institute. So I said that I think I can help us to facilitate the professor of science engineering in our college. And I will thank you to all the students. जो आया वो आया और जो नहीं आया वो पढ़ा. So there are many students that are not going to So I hope that in the next seminar, we have a huge gathering of students all over Bali because 2024 we provide exams, so they are not included. But 25 batch, 3 batch, 23 batch, 32 batch, 21 batch, all over Bali will be there. We select 3 students from each batch. If anyone is interested, please give the name to your CR or LR or PR so that we recognize this time we are discussing about one name. The person of non-member is supposed to present, but his name was circulating, so that should not happen. So please submit your names to your PR. Then we will finalize the topic, we will finalize the date, and we will finalize the participants for this. So thank you very much for coming, sitting here. Thank you.